And then in the panel, this thing, I have removed this thing, sir's name, panelist from the.
Dr. Kaushal Patel's name, na?
Yeah, yeah.
Great. Wonderful. Things look all sorted now. I hope everything will go fine.
Yes, sir.
Yeah. Good evening, Mehboob, sir. Welcome to the meeting.
Hi, good evening, good evening.
We're just waiting for the other faculty members to join, sir, and then. Good evening, everyone. I, Dr. Yogendra Shokin, Medical Manager Oncology at Merck Specialties, welcome you all to today's discussion on real world evidence in urothelial cancer. Urothelial cancer, as we all know, is a complicated disease to manage. We have come a long way from treating bladder cancer with the introduction of BCG in the bladder to chemo combinations and now to multiple immunotherapies being in this space. So, inclusion of multiple therapies on one side has provided us the choices to personalize the treatment. On other side, it has created a sort of confusion about which therapy should be chosen for a particular patient. In such an era, it becomes really important for clinical discussions to be done regularly. Today, carrying forward Merck legacy of creating platform for such discussions, we again welcome our renowned faculty for the meeting. To chair the meeting today, we feel honored to have Dr. Mehboob Basade with us. Just a second. So, Dr. Basade, as we all know, is one of the most renowned oncologists in India. He carries himself with the rich experience of more than 22 years. So, he has previously worked as a uh, dep- uh, head of Department of Medical Oncology, Medical and Pediatric Oncology for Tata Memorial Center, Rural Center projects, and also for Nargis Dutt Memorial Cancer Hospital. He had been associated with many research projects and particularly with phase 2, phase 3 clinical trials and studies as principal investigator. He has been accorded with multiple awards like with international scientist visiting fellowship in oncology at St. Jude's Research Hospital, which was again followed by another fellowship at New York Hospital, Dr. Cornwell Medical Center in New York. So he was also selected as one of the top three students for Young Medical Oncologist Fellowship offered by ESMO uh, to the uh, to the Institute of Gustavo Rossi in Paris, France. So it's a real honor to have you with us today, sir. And we again welcome you to this meeting as a chairperson. So without wasting any further time, I invite Dr. Mehboob Basade to take the meeting and take the meeting ahead. Over to you, sir.
Thank you, Dr. Yogender. Good evening to everybody. Today we have joined together here online just to discuss about what's new in the management of metastatic urothelial cancer. We all know that any metastatic disease, we always try to look and balance both the quality of life and the survival. That's more important. And we have multiple options now for the management of these urothelial cancers. Which option to choose first, which should be the second one? These are all very important questions in our mind, and today we will be discussing all about that. So we have two basically lectures, one by Dr. Sachin Gupta and other by Dr. Amol Dongre on the real world evidence in the advanced bladder cancer. One on global data, Dr. Sachin Gupta will discuss on the global data, and Amol will discuss about the Indian data, and then we will have case presentation and the panel discussion. So over to you, Dr. Sachin.
Thank you, sir. Thank you, Mehboob, sir, for your wonderful introduction. And thank you, Mark, for organizing this meeting. And should I go ahead, sir? I hope I'm audible. And slides, Dr. Shakin, can you do it from there? Because I'm joining from my mobile.
Of course, not a problem, sir. So
Yeah.
vendor will take care of that.
Yeah. Thank you. So I'll be presenting about the real world evidence from the rest of the world, and Indian evidence would be discussed next by Dr. Amol. So we know that now there is a lot of interest in treatment of advanced bladder cancer, and as we are seeing that a lot of new advancements have come in last few years with the now ADCs and immunotherapy drugs are being used. Earlier we had only chemotherapy drugs for this particular cancer. Now this is how the treatment landscape for bladder advanced bladder cancer has been improving over the years. So classically, we have been dividing these patients into cisplatin ineligible and cisplatin eligible. And of course, so if cisplatin cannot be used, then we use carboplatin instead in the first line, and gemcitabine being the other partner drug. And once these patients used to progress, so we were using taxanes mainly. So this vinflunin is not available to us, and in the second line, the response rates are pretty dismal. So they are in single digit, and also the median OS and 1 year OS rates are also not impressive to the tune of nearly 7 months and 27%. Next slide, please. So in second line, now there is the immunotherapy when it was used, it showed better responses in second line. So with immunotherapy, the objective response rates improved to double digits to the tune of 21%. And also there was improvement in the median OS and 1 year OS rates. So 1 year OS rates raised nearly to 44%, and median OS was nearly 10 months. So immunotherapy does add value when used in the subsequent line of treatment after having exhausted the chemotherapy option. Next slide. Now, if we see what happens historically, so there is high attrition rates in each subsequent line of treatment. So when we start with the so let's just focus on the right hand side of this slide. So if we involve nearly 100%, let's say 100% patients are newly diagnosed and being treated, then in first line only less than half are reaching second line of treatment, and nearly 17% patient used to receive second line therapy, and the third line treatments are of course dismal to single digit of only 6%. So which means a lot of improvement needs to be done in subsequent lines of treatment. And so now we see how things have evolved in last, let's say, 8-9 years or so. Next slide. So now if we see what all is available to us today and how the algorithm has changed. So with the availability of more and more immunotherapy drugs and ADCs, now what has happened is that, so after platinum based chemotherapy in the first line, we have maintenance avelumab. So that is one way we can treat it. Or if the patient has progressed, then of course we can use single agent immunotherapy as such also. And if the patient, so we can also use upfront immunotherapy here. So there is data about gem, platinum, and nivolumab, and subsequently nivolumab maintenance. And if the patient is elderly, frail, or due to any reasons because of renal dysfunction, obstructive uropathy, if platinums cannot be used at all, then we have this chemotherapy-free regimen of ADC plus IO, which is EV plus pembrolizumab. So this data is also available for such group of patients. So this is how these days advanced urothelial bladder cancer is being treated. But of course, we have problems that what to do next after having exhausted these lines of therapy and the available options here. Next slide, please. Now sequencing is now mattering a lot because we have availability of all these agents. So the problem is how to use these agents, in what sequence do we use, and which agents are to be used first. Whether we use immunotherapy upfront as in GEM-CIS nivolumab trial, or we follow a regime of giving chemotherapy followed by avelumab maintenance. And of course, once the patient progresses, we have options of EV or doing a NGS test. And if we find some mutations such as FGFR, etc., then we have some drugs like edafitinib, etc., which are for targeting FGFR receptors. So we'll be discussing how the sequencing may be done in the subsequent slides. Next slide. Now, Javelin Bladder 100 was the most important trial with avelumab. So where avelumab was used as a maintenance treatment after having done chemotherapy upfront. And patients who discontinued avelumab first line maintenance and received subsequent treatment. So this table shows that what all treatment these patients may have received subsequently. And so here we can see that if the patients were only on breast supportive care, majority of these patients would have received subsequent immunotherapy drugs, and very few patients are there who would have received FGFR inhibitor, and but majority would have received some other drugs, so which could be chemotherapy also. And so the most common other drugs which were given after avelumab first line maintenance were gemcitabine, carboplatin, paclitaxel, vinflunil, and cisplatin. So mainly these patients received chemotherapy, majority of them. Next slide, please. Now we have many phase 3 randomized trials, but of course we know in the real world there are a lot of challenges, and because in trial patients are very well preserved patients with good performance status, but in the real world the performance status of patient may not be that good. And and we have a lot of comorbidities with our patients, and these patients with comorbidities are often eliminated from the trial. So the real world setting is different than the actual trial setting. Next slide. So we'll be discussing some real world trials and whether this data is equivalent to what Javelin bladder 100 trial shows, whether the response rates and OS, PFS are similar to that. Next slide. So now we have this global real world evidence for Avelumab maintenance for more than 5,000 patients across the globe, and with the US and Latin American countries, Europe and Asia Pacific contributing to many of these cases. Next slide. So this is the snapshot of all the trials, and here we can see there is a Flatron 2 US trial, then there is a trial from Turkey, then Patriot from US, Avalanche trial from France, Tempest from US, Ready study from Italy, and from Russia, and then from Europe as well. So now this captures the median PFS, which ranges from 5 months to nearly 11 months, and also the 12-month OS, which is 71 percent in Javelin. So in the real world, it is 63% to nearly 79%. So the median comes to be roughly the same for all these studies, and so the real world data broadly resembles the Javelin bladder trial data. Next slide. Now this shows the median OS from start of first line maintenance, and so this is platinum based chemotherapy, and patients who did not progress on first line platinum based chemotherapy. So Javelin is shown at the bottom, which is nearly 29.7 months, and the rest of the trials show nearly 22 months to 38.9. So the highest is 38.9 in one of the trials. So again, if we see the average, it again comes out to be nearly the same. So the real world evidence is similar to the Javelin trial data. Next slide, please. So these are the safety outcomes for Avelumab, and this is again seems to be consistent with Javelin, and with grade 3 and 4 toxicity, which was nearly 20% in Javelin. And in the real world, rather the toxicity, the advanced toxicities are a little less, as we see here. Next slide, please. So this was a French study, evidence study. So it included previous or ongoing or planned Avelumab first-line maintenance treatment that did not progress after first-line platinum-based chemotherapy. And Avelumab dose was 800 mg 2 weekly, and OS was seen, and also the PFS duration and OS by second-line treatment. Next slide. So here the median OS is 21.3, and 1 year OS is 66, and 2 year OS is nearly 46%, with the median PFS 5.7 months. Next. Now, historically, in real world studies, about 25 to 50% of patients with the locally advanced and metastatic urothelial were receiving subsequent treatment following first line platinum based chemotherapy. So in Eminence study, it is 82%, and in Javelin, it is 75.6%. So this is the number of patients who are receiving subsequent treatment. Next slide. So this is the way the subsequent treatment has been given in this particular study. So after Avelumab maintenance, so nearly 20. So after a follow up of median 26 months, About 21% patients are still on Evolumab first line maintenance, and rest progressed. And in the second line, about 19% have received ADC, which is basically EV, and about 74% have received some sort of chemotherapy, and about 7.3% were other treatment, which could be FGFR receptor inhibitors. Next slide. So now if we see a contemporary sequence of Javelin bladder regimen followed by second line EV, this is achieving a median OS of 40.8 months from start of first line platinum based chemotherapy. So can we go to the previous slide? Yeah. So if we concentrate on the green column here, the second line ADC, so the median OS is 40.8, and the 1 year OS and 2 year OS rates are the best. So sequencing with ADCs is making a big difference here. So this is giving the maximum median OS. If we sequence first line maintenance Evolumab followed by EV, so this is giving the best overall survival so far. Next slide. Now, in a Japanese real world study, complementary findings to evidence showed a median OS of 40.3 with the Javelin bladder regimen followed by second line EV. So, this particular thing has been validated in another study in Japan also, where median OS of 40.3 months was found. So, this was against 24.7 months median OS in patients with PD on first line platinum based chemotherapy. Next slide. Okay, so this is the study we're talking about, and so there is another Japanese real world study where 42 months median OS has been shown. Next slide. Okay, so this is the median OS data with many other studies. So where second line ADCs has been used, and if we look at this data, so median for second line ADC from the start of platinum based chemotherapy. So this Japanese and French study are showing nearly 40 months, and then there are with studies with more patients where the similar thing is 22 months, 31 months, and so on. So this data is variable, and the number of patients are also different. And but we can see that some of the studies are going up to 40 months plus. Next slide, please. So now we have this algorithm. So this is a proposed algorithm where patients with advanced or metastatic urothelial carcinoma, first we see the chemotherapy and platinum eligibility. So on the right hand side, it is platinum ineligible actually. So this is a misprint. So if ineligible, then we can go directly to EV Pembro. And if platinum eligible patients, and we try to give cisplatin wherever possible, and we can combine nivolumab upfront followed by maintenance followed by second line treatments, or we can follow it with maintenance evolumab and on progression use EV, so which is a ADC. So this is the proposed algorithm which most of us are following these days. Next slide. So now this is the study without chemotherapy arm, EV plus Pembro outcomes outside clinical trials. Now the overall response rates and the disease control rates and 12-month OS, and these are shown here. So the 12-month OS is 58, 67, and in the treatment refractory it is 52% also. And if prior immunotherapy has been used, then the 12-month OS percent is nearly 56%. Next. So now these are some real world outcomes and studies. So in the Unite population, overall response rates was 54%, 12-month PFS 30, and 12-month OS is 67. So which is less than the original uh, EV103 cohorts, and which were in the tune of 80% and plus. So in the real world, the overall response rates and OS is less than what was shown in the original study. Next. Okay. So now there is some difference in the real world evidence as compared to the original EV Pembro trial. So there's some reduced effectiveness in those with uncertain urothelial cancer subtypes, and also the variant histologies or distant or bone metastasis, and those failing to achieve early ctDNA clearance. So there is a large retrospective study of 232 patients which shows reduced CR versus the EV302 population, 22% versus 30%. So there is comparison with data from two large real world studies here. So there is a suggestion that in actual practice, the results of uh, EV plus Pembro trial are not replicated. Next. So now if we use EV plus Pembro in the first line, then what do we do subsequently? Because these patients are, usually they tend to be platinum ineligible already. If they are somehow eligible, then of course we have choice of using some sort of chemotherapy. But if they are ineligible, then we are not left with much choices beyond some targeted agents according to the results of NGS-CGP. And so dafitinib, sacituzumab govitecan, and taxane. So these has been used beyond this, but otherwise we don't have much options because we have used ADCs and IO drugs already in this situation. So that becomes a challenge. Next. Now 59% of patients in the chemotherapy arm receive subsequent IO drugs, and after EV Pembro, the first subsequent systemic therapy could be platinum based, could be again IO followed by, but that was very small percentage of patients. So we are not left with many choices here. Next slide. So to conclude, we have many options these days for treating advanced urothelial cancers, but it becomes increasingly important to understand how therapies are being used in practice and how they are being impacted in the real world, and how do we sequence them. So we need to study the results of Javelin, that the way the patients are being managed in this fashion by using maintenance IO followed by second line EV or other drugs, versus using upfront IO drugs or ADCs, and having lesser options in the subsequent line of treatment. But if we look at all this data, the sequencing of chemo followed by IO followed by ADC drugs, this seems to be giving the longest median OS as of now. The rest we can discuss subsequently in the panel discussion. I think this was the last slide. Yeah, thank you.
Thank you, Dr. Sachin, for
Yeah.
taking us through the global data. Yeah, over to you, sir, Dr. Mehboob.
In data.
Looks like Dr. Mehboob is facing some connectivity issue. So once again, thank you, sir, for taking us through the global data and how it is in alignment with Javelin 100 data, the clinical outcomes which has been demonstrated in Javelin Bladder 100. So for the next session, I would like to invite Dr. Amol Dongre. So next session is going to be on Indian data, that is RWE in bladder cancer, being focused in India. So how it is different from the what we have observed in the global data. So Dr. Amol Dangre is actually Director of Medical Oncology at Max Alexis Super Specialty Hospital in Nagpur. So welcome you, sir, to today's meeting, and request you to take over the meeting and take your session ahead.
Hi, good evening, everyone. First off, at the outset, I would like to thanks Mark for giving us this opportunity and this, unmet need to uh, talk about locally advanced metastatic urothelial cancer and what's about the maintenance in that. I mean, we all know, and just now Dr. Sachin has presented a global data about, on local advanced metastatic urothelial cancer. So I'll be presenting a real world outcome for maintenance available treatment in Indian patients with locally advanced metastatic urothelial cancer. I just want you people to please change my slide. I don't have access to my laptop now, so I'll be doing on computer. Yeah. So basically, the real world outcome for maintenance available treatment in Indian patients with locally advanced or metastatic urothelial cancer was presented at ISMPOCon in 2024. And I mean, this has been basically the study was done by Dr. Vineet Talwar, Dr. Kaushal Patel, Chandra Godadi, Dr. Tushar Patil, Akhil Kapoor. So basically, it's a multi-centric trial. So available maintenance after first-line platinum-based chemotherapy in locally advanced or metastatic urothelial cancer has been shown overall and progression-free survival benefit in Javelin 100 bladder trial. We all know, and just now Dr. Sachin has also discussed. So the analysis of demographics and real-world outcomes from Indian patients who are receiving this available maintenance is what is present in this. So this is again a multi-center non-intervention retrospective patient record review was carried out for patients who have been treated with available maintenance in Indian setting, and survival outcomes are established using Kaplan-Meier. So the key outcome measures include the overall response rate, PFS and OS. You see a total of 42 patients were included, in which mostly 81 were male and 81% were male and 19% were female. After this first line platinum based chemotherapy, almost 12% had a complete response and 59.5 had a partial response. So if you see this table one, it shows the baseline clinical characteristic. So right, as I said, 81% of male, 19% female, and most of the primary tumor in the lower side, and then first line chemotherapy regime in almost 52% was gem carbo. As we all know, in advanced patient we tend to avoid using cisplatin. 40% of gem plus cis, and in 7.1% there was dosed as MVAC. So if we see the CR, PR, and stable disease, so 12% patient had CR, 59.5 at PR, and almost 26% had stable disease. So treatment free interval between chemotherapy and avelumab less than 4 weeks in 26 patients, 4 to 6 weeks in 55 patients, and 6 to 8 weeks in 14.3 patients. So basically, patient were proceeded to maintain available treatment within 4 to 6 weeks of completion of this first line platinum based chemotherapy, and less than 4 weeks in almost 26.2%. So, if you see the median duration of available maintenance was 6 months with an overall response rate of 16.7%, and the median PFS was 5 months. In patient who received available for more than 6 months, the median PFS was 11 months. So, you can see the Kaplan, the median PFS was almost 5 months. The median OS was not reached, and the 12-month OS rate was 82.1%. So the conclusion of this study is basically This is the first multi-center Indian real-world data confirm that avelumab maintenance treatment is well tolerated and its efficacy data is consistent with previously reported clinical studies. So this is our own Indian study. So coming to the background, so after first-line platinum-based chemotherapy in locally advanced has shown overall progression-free survival Javelin bladder 0 trial. Next slide, please. Next slide. So basically, this analysis of demographics and real-world outcomes from Indian patients who are receiving avelumab maintenance. Next slide. So, as I said, this is a multi-center non-interventional study with key outcome measures include overall response rate and PFS and OS. The survival outcomes, including PFS and OS, were analyzed using Kaplan-Meier survival curves, and the quantitative variables were summarized as either mean or standard range, while qualitative variables were present in the form of frequency and percentage. Next slide, please. So results, as I said, total 42 patients, median age was 64, range with 33 to 83, and 81% female. After first line platinum-based chemotherapy, 12% had a complete CR and 60% has almost PR. Next slide. So the median duration of avelumab maintenance was 6 months with an overall response rate of 16%. And 4 patients out of this 42 had a complete response and 3 had partial response. The median PFS was 5 months, as shown in this figure. And in patient who received avelumab for more than 6 months, it was 11 months. Next slide. Again, if you see the median OS, it was not reached, and the 12-month OS rate was 82.1%. Next slide, please. So the authors conclude that this is the multi-center Indian real-world data which confirms that avelumab maintenance treatment's efficacy data is consistent with previously reported clinical studies, as we have seen in Javelin bladder trial also. So if you, next slide please. So if you ask my experience with avelumab in locally advanced or metastatic urothelial cancer, I have 2 or 3 patients whom I have started avelumab after finishing first line gem and carbo. I have never used cisplatin in my advanced urothelial cancer patients, and I do have good response with avelumab. In fact, I have experienced more with RCC than urothelial, but yes, urothelial carcinoma, they also do better with this avelumab maintenance. My only point is, one is when we have to start. So I have started in patients because the assistance is not that great. I'm sorry to say this. But then I have started almost 6 to 8 weeks after finishing the platinum-based chemotherapy, because most of the patient, they need some time that they have been tired of taking chemotherapy. So little delay, but then 3 of my patients, out of which 1 has really done well, rest 2 patients have not that great, PFS. So with this, I'm done with my presentation. Thank you.
Yeah, thank you, Amol. Thank you very much.
Thank you.
So let's move to the next one. Will be panel discussion by Dr. Akhil Kapoor. Akhil, you can invite your panelist.
Thank you, sir. Thank you, Mahbub sir, and the entire team. So please allow me to share. Yes. Okay. I would like to share directly from my end. Yeah. So I invite the panelists, Dr. Vikas, Dr. Satish, Dr. Rohit Swami, Dr. Devapriya, Dr. Monica ma'am, Dr. Sachin, Dr. Amol, Dr. Kaushal. Hopefully all of you, most of them are there.
Sir, Dr. Kaushal Patel will not be able to join.
Okay.
He has some challenges at his place.
Okay, fine. Okay. I can see most of others, my dear colleagues and seniors, I can see on the screen. Nice to have again see my dear seniors on the screen. So let's move to the panel. So what have been the milestones in the treatment of urinary bladder cancer? We are all aware, and I think we'll come to directly the point. We know that avelumab first-line maintenance has prolonged overall survival. That was the first study which actually directly looked at prolonging overall survival instead of PFS, which was very common utilized previously. But thankfully, this study took into account progression-free overall survival, which was very daring in fact at this time when this study was started. And also at the same time, there was a protocol of DD-MVAC and MVAC. I will just start comments from my panelists. Monica ma'am, do you use MVAC or DD-MVAC in your practice anytime?
No,
Aesthetic setting, ma'am?
I've never used a DDM-VAC. I have no experience with that. I've never used it. It's always been in platinum eligible patients, either GemCis or GemCAR, depending on the cisplatin eligibility. Otherwise, a non-chemo based approach is what I'm using. I've not used DDM-VAC in anybody.
Yeah, I agree, ma'am. We also tried to start, but due to toxicities, most of the time we had to stop.
Toxicity is a major challenge. Yeah.
Myelosuppression is very, very significant, and it's very difficult to utilize. So we stopped utilizing it, though it has.
Akhil.
Yes, ma'am.
I have given in 2 patients NACT in bladder. Those days MVAC. Response are really great, and touch wood. I mean, 4 years. I mean, this patient is doing it. It's a non-metastatic advanced bladder preservation. So, in patients I have used, though it's a toxic protocol, but then it really works. In fact, one of the got progress after gem carbo. I mean, there's no response after gem carbo, and after giving dose days MVAC, he has almost complete response, and then took definitive CTRT.
Okay.
So toxicity is an issue, but otherwise it's a good protocol.
In very extremely fit patients, probably we can definitely consider, especially when we are looking at curative intent.
Yeah, young fit curative intent patients with the good performance status, good nutritional profile. There we can select, especially in ACT setting.
Correct.
In metastatic setting, I think it's really difficult. And
not in metastatic setting, absolutely.
Metastatic setting, the focus on the quality of life, not getting the PATSI or something like that. So I completely agree with the comments of both my seniors. So let's.
I will also say that even though we would be inclined to use DD-MVAC protocol, but at the end of the day, when one third of your patients, in fact 36% of your patients who are going to receive DD-MVAC are going to have a greater than grade 3 or 4 tox Ts, and they are going to land up hospitalizations as compared to less than 15% with the GemCis protocol. And possibly if we go by the numerical data, the pathological complete response is not numerically great. So 25 versus 35. So I believe we have to be very, very careful in selection of the patients where we want to give DD-MVAC, because most of these patients, because of the bladder disease per se, they are very borderline in PS in terms of they have ongoing hematuria, they are post some form of surgical interventions, TURBTs or things. So a lot of them are going to land up in febrile neutropenias and are going to be candidates for mortality, and especially risky is the neoadjuvant settings.
Completely agree. So I think Dr. Vikas also resonated the same point. And I think we all will agree that DD-MVAC or MVAC is not a common regimen in our practice. And it is only utilized in very selected young fit patients in anesthetic setting, not in metastatic setting. Now coming to the metastatic setting, advanced setting, where the treatment is started with either a palliative intent or where we know the N3 disease burden, something like that is there. Rohit sir, your comments. How do you, what percentage of your patients are fit enough to receive GemCis protocol or versus GemCarbo? How has been your experience, and how do you select these patients?
So I'll say cisplatin eligible patients will be around 50 to 60% in the practice, and around 30 to 40% of patients are not fit for cisplatin, and we go for GemCarbo with them. And if there is a good response, then we can always go for avelumab maintenance.
Got it. Now there is also a data of combining GemCis with nivolumab. Dr. Mandal, I would like to take your comments. Yeah, if you can unmute yourself.
Yes. Almost half the patients are not eligible for cisplatin.
Yeah. And how do you decide the regimens of using Gemcis or Gem Carbo followed by Avelumab versus Gemcis Nivo in cisplatin fit patients?
Um,
Yeah.
usually, if a patient has received prior adjuvant therapy, there is no guidance, but my thought process is that if a patient has received prior adjuvant therapy, then I prefer to use the immunotherapy upfront. I'm of course speaking about cisplatin eligible patients. In those, I prefer nivolumab with Gemcis.
Okay.
Others, I choose. I mean, both are acceptable options.
Okay.
And with Gem Carbo, avelumab is the option.
Yeah. I think patients where there is no fitness for cisplatin, the straight option is Gem Carbo, 4 to 6 cycles, and then Avelumab maintenance. In patients who are fit for cisplatin, there are these two options, and we need to select between them. Dr. Sachin, sir, your comment on that? Gemcis Nivo versus Gemcis or Carbo followed by Avelumab maintenance. How do you
Yeah, broadly, I agree with Dr. Mandal, and this is the way. But I am so it's usually easier if the patient is platinum eligible and giving only chemotherapy and following it up with immunotherapy is usually a easier option and easily available option. And because there could be cost constraints also, and taking immunotherapy upfront uh, is little difficult most of the times. So I'll prefer the sequencing way more.
Okay. And thank you, sir. Thank you, sir. And Dr. Amol, sir, are you convinced the data of Gemcis Nivo in the practice? The data of benefit efficacy data of Gemcis Nivo?
Well, see, I've not used Gemcis Nivo, but yeah, in a cisplatin eligible patient, especially what Dr. Deviprey said, so I totally agree with him. I would use it in a cisplatin eligible patient. Otherwise, my choice could be Gem Carbo and followed by maintenance available.
Okay. Monica, ma'am, you would like to add anything? Fit patients for cisplatin, Gemcis Nivo versus Gemcis followed by Avelumab. How to select any pointers?
I think in a subgroup analysis, patients who had liver metastasis, I think they did a little better with Gemcis Nivo as compared to, I mean, the hazard ratios, if you see, I think they're a little better in patients who have lot of visceral disease, lot of liver metastasis. Maybe in that kind of a patient, I would prefer to give immuno also because the response rates are a little better when we add on immuno from the beginning. So that is one way, although this is just like a speculation. We don't have any solid evidence to back this up. It's just based on that small subgroup analysis. But apart from that, I really don't see a clear, strong reason to choose one over the other. And in cisplatin eligible patients, I think either are fine. But maybe the response rates are a little better. So somebody who has a lot of visceral disease burden, a lot of lung and liver metastasis, maybe them I would tend to use nivolumab, Gemcis. I would like to introduce IO from the beginning, and as in contrast to using them in a sequence.
Okay. So I think there are no direct answers to it, and we need to utilize our own judgment and select the treatment which is best possible suited for the patient. If we see the various subgroup analysis which are available, as Monica ma'am highlighted, it is speculative only. Only in the subgroup where the patient had nodal only disease, that patients did somewhat better with Gemcis Nivo protocol as compared to Gemcis alone. And the most important pointer which I take in my practice is that this trial did not incorporate avelumab maintenance because this trial, avelumab maintenance trial, was not published at the time when the trial was started. So, and also there was no PFS advantage of there was PFS advantage of just 9 days with Gemcis New as compared to Gemcis. So that makes me think whether concurrent immunotherapy along with Gemcis is actually needed and it is actually doing anything, whether it is only the component which is doing after Gemcis part, whether it is working. So this is my thought process, but yes, I agree. Since there are no direct comparison, we can't have direct answers. But in my practice, I tend to prefer Gemcis or Gem Carbo followed by avelumab maintenance. And the most important point which I take care is that the patient who has received around 3 to 4 cycles, I tend to shift to avelumab maintenance as early as possible. Rohit sir, any comment on that 4 versus 6 cycles, and how do you select between these two, or whether the patient starts having toxicities, then you switch early? What is your selection, sir?
If response is very good after the 4th cycle only, then we can switch to the maintenance avelumab. And if even after 4 cycles there is quite heavy burden of disease left, then I'll go for 6 cycles. And if there are toxicities, much more toxicities after 4 cycles, then again we have to switch to maintenance immunotherapy after 4th cycle.
Okay. I think that's a very valid selection methodology. Like in lung cancer, where the data is that PEM carbo 4 versus 6, 6 is not superior to 4. Something like that trial is already recruiting gem cis or gem carbo 6 versus 3, followed by avelumab maintenance. That trial is already recruiting. And I think that will help us to know the exact answer. But what I have found, the most of the time, especially when we are using carboplatin, the most patients will start developing myelosuppression after 4 cycles, leading to multiple delays, leading to poor dose intensity of the treatment, leading to delayed treatments, and in that duration, patient might progress as well. So that is one of my take. That is why I tend to shift in all patients receiving either GemCis or Gem Carbo to as early as avelumab maintenance when was feasible. Vikas, sir, you would like to add anything in relation to this? Do you agree?
I totally agree. So I also feel that 3 points which I would like to draw: the checkmate 901 trial, which was the trial which was originally designed, also had one arm which included ipilimumab, which was again stopped because of the interim data safety analysis proved its futility, and it was never ever marketed. Also, if we look at the cumulative toxicities in terms of the grade 3, grade 4, adding immunotherapy doesn't leads to increase PFS, but it does leads to increase grade 3, grade 4 toxicities, nearly 20% more than the what was the Javelin trial was supposed to. So I think even if you look in the short run also, these patients are going to be possibly not completing the therapies, going to have more uh, pondering toxicities, and they are going to drop out very easily. Bladder cancer has always been a sequence, so possibly how many of them could have been salvaged with the EV regimen downline is somewhat is a point to look forward to. Till that time, I'm a fond of 4 cycles gemcis followed by maintenance avelumab, simply because you get the best of both worlds. You get best of chemotherapies, you get the good response rate, patient goes into a good CR or partial response, and then you put them to avelumab maintenance to consolidate what you have achieved with it.
So that's all the points were very valid and utilized. So this point we have covered cis versus carbo, avelumab maintenance, and how now there is one other point that we would like to see. Median PFS of 26 months in patients who were receiving avelumab maintenance for more than 12 months. So this is, I think, quite understandable. In patients who are receiving immunotherapy, those patients who are doing well initially, they are likely to do well for a longer duration. This is landmark analysis data. We have seen it across multiple trials of immunotherapy, and that remains the same. Patients who were exposed to avelumab for at least more than 6 months, 47% patients were doing well and were continuing treatment. And there were 20% patients who were exposed to avelumab for more than 24 months. That is quite good. 1/5 are patients receiving treatment, maintenance treatment for more than 2 years. What more you can want? And so that is best part. So this is the best part, getting a patient staying on maintenance treatment, which is primarily non-toxic most of the time for more than 2 years, at least in 1/5. And we want to increase that 1/5 by some of the other mechanism. But yes, that is there. That is what we need to see. So yes. So now moving further, we have seen this data sets of maintenance treatment OS data. So good part is that if we see the OS data, it is 15 versus 24 or 25 months. So again, 10 months OS benefit is somewhat like, I remember in a way, CDK4/6 data sets across metastatic breast cancer, where it was similar data of 15 versus 25. So that has shown the benefit. Avelumab maintenance has shown similar OS benefit. And that CDK4 data was PFS for 15 versus 25. Here we have OS benefit of 15 versus 25. So that is one of way I tend to remember this data. Now, coming to another area, which is EV plus Pembro. How to select EV plus Pembro in some selected patients in the baseline itself. The data is strong. EV plus Pembro data is very strong. How do we select whether EV plus Pembro, if affordable, though it is a combination which is very costly, both the drugs, immunotherapy and EV, I think in our patients, we are struggle to utilize single immunotherapy and we try to utilize low dose immunotherapy many of the times. Here we are combining two costly drugs. Any comments on that? Dr. Mole, sir, would like to comment first, then I will request Monica ma'am.
Well, as you said, it's very difficult to give in our set of patients considering EV with Pembro. I mean, I have never used EV in my patient, so I'm really not aware of the data.
Okay. So, Monica ma'am, any comment on that? We have utilized EV in second line in a lot of patients.
Yeah.
Thankfully, we have phase 4 trial as well, EV. So any patient who has received immunotherapy in the either first or second line setting, then we have a phase 4 trial that has helped us to get more experience. We have around 20 patients on EV now, and that has done well in second line setting. But first line EV plus Pembro, how do you see the data, ma'am? And how do you select those patients for first line EV plus Pembro versus Gemcis or Gemcarbo followed by Avelumab?
Yeah, for now, I would probably restrict it to the platinum ineligible patients. That is one thing. The response rates and the median OS are very, very impressive from this trial. And it would be compared to cytotoxic chemotherapy, obviously, it would be a less toxic, better tolerated regimen. So maybe in very fragile elderly patients, also, I would prefer this regimen. And in those who are platinum ineligible, but it's not like a blanket for, putting affordability aside, let us consider a scenario where everybody is able to afford for the discussion purpose. I would restrict this regimen probably to the very elderly patients who are fragile, cannot handle cytotoxic chemotherapy, even if they're not strictly platinum ineligible, as well as in platinum ineligible patients, I would consider this. Otherwise, I would go for IO with chemo initially and reserve this for the second line.
Yeah, I think that's a very valid comment. Patients who are clearly platinum ineligible, that means even carboplatin ineligible due to GFR of below 30, there we can consider EV plus Pembro as an option when funds are feasible. Regimen is very costly. Besides that, another point which we must understand is that the trial, EV plus Pembro trial, did not take any patient who had GFR below 45 ml per minute. So though we think that EV plus Pembro is a good option for platinum ineligible, and that makes sense also by the usual understanding. But we must understand EV plus Pembro trial had exclusion criteria of GFR below 45 ml per minute. So we don't know the data in that particular subgroup, whether these patients will be doing good or not. And the same PFS and OS data will be applicable for that group. Dr. Debapriya, you would like to add anything regarding this?
Yes, very practical concerns raised by you and Monica madam. I actually have a recent experience in two patients where the creatinine clearance was, patients were more than 75, creatinine clearance was 30 or below. And I was just reading up this another, I think, real world study criteria EVITA, where they do not recommend enfortumab vedotin in patients below a creatinine clearance of 30. But then people who have used it, I got in touch with some of colleagues from the other countries, and they are all of the opinion that it does not matter. So I have started using it. So far, luckily, there hasn't been any toxicity, even in patients below a creatinine clearance of 30.
Yeah. Okay.
So they were strictly ineligible, like you have told. for any other cytotoxic
Akhil,
or
one more thing.
Yes,
I think this because the response rates are very good, like the CR rates were close to 30% in the Pembro EV trial. So in maybe patients who have again a lot of visceral disease burden, we want a rapid response. Maybe they are the ones who would also benefit from this particular regimen in the first line.
Very valid point. I completely agree, ma'am. Where we know the patient might rapidly progress on gem carbo or gem cis sometimes, that patient we can select. Completely agree. And we have sometimes tried to utilize that regimen when the patient is not fit enough to receive other regimens, and that has worked some of the times. But yes, we must be aware of this data's drawbacks and fallacies, as Dr. Devapri also highlighted. In this EV plus Pembro trial, actually, in the control arm, GemCis or Gem Carbo, only 30% of the patient received Avalumab maintenance, so which is one of the important points. So we expect OS to be significantly different if control arm is not strong enough. 70% patients in the control arm not receiving the standard of care treatment actually. So that is one of the important fallacy which must undertake. And a point was very valid that where we know the patient will not respond to GemCis or Gemcaro will have likely to have upfront progression, there we can consider this regimen. There is no direct way or molecular data to know whether it will work or not. We are trying to work on that Nectin-4 amplification test that is not available in the country. We are trying to develop it in-house so that we can know, because there is some hint that if Nectin-4 amplification is not there, which is likely to be there in around 30 to 40% of the patients, these patients, despite being fit and affordable for EV plus Pembro, they have response rate of only 32%. So that is important point which we should take care into account. Though in the trials, they have taken it across the group and they have taken it across all the settings. This is how the trials are designed by industry. They try to utilize in broader proportion of the patients. But if we are try to understand the nuances and try to find the best possible biomarkers, I think there is a way to find it, and we need to look at it. Vikas sir, any comment on that? No additional comments. Okay, okay. Now let's see some.
I'm sorry, I was on mute. So I am still a fan of EV plus Pembro, but I believe every drug should be given its good test of time. EV plus Pembro does have its fair large number of toxicities, even though we say it's a chemo-free regimen. But at the end of the day, if you dissect the data, nearly 70% of the patients do get up some form of dermatological toxicities. 30% of them do tend to get a good grade 2 to 3 dermatological toxicities. 50% of them land up with peripheral neuropathy, and around 25% of them are going to get a good amount of grade 3, grade 4 peripheral neuropathy. Pneumonitis component, if you look at also, so 10% of the patients are going to get a good grade 2, grade 3 pneumonitis. Ocular toxicity, plus all those patients who had HbA1c raised or an impaired glucose were excluded from the trial because of their component MMA causing hyperglycemia. So we don't know how the diabetics are going to perform with the combination. So I believe it should be taken with a pinch of salt. And the bone of contention will be how many of these EV plus Pembro, when are going to progress, are going to get chemotherapy in the second line, or they are going to get eligible to get chemotherapy in the second line. So I believe if they are eligible in the first line, give them chemo and then reserve these drugs in the sequencing. Still would propagate Javelin till the time we have good comparisons, as you rightly suggested that you had to suppress the control arm to publish great data out of that EV plus Pembro study. So we will need to dissect that data carefully.
Completely agree. It's very important points highlighted by Dr. Vikas. And again, the toxicity is significant. We have utilized EV at least in 20 patients in the second line setting. It is not an easy drug. We need to reduce doses in close to 50 to 60% of the patients. It causes neuropathy. It causes hyperglycemia. patients of older patients who already have hyperglycemia, HbA1c raised, it is not permitted by EVITA, modified EVITA criteria, which is discussed a lot of times. If HbA1c is above 8, and if there is neuropathy, existing neuropathy, I think these are important points which we should take into account. And also, the overlapping toxicities, for example, skin rash, whether the skin rash is due to EV versus due to immunotherapy, that becomes an issue. Whether the whether it is ILD is due to immune mediated or versus EV, it's again a problem. And that is the worst part with such treatments, when you don't know how to manage the toxicity, because you don't know which drug is causing that. So that is most difficult part actually. If everything is fine, it's fine. But if the patient develops any grade 2, grade 3 toxicities, management is actually very difficult. Especially, we have seen some ophthalmological side effects, corneal ulcers, leading to discontinuation of the treatment, and that has been already reported. So these points are important, and that should be taken into consideration when we are utilizing these treatments, because our focus should be on maintaining quality of life as long as possible. So if any toxic drug is being utilized, it should be as a small duration as feasible. So we have the data from Evidence study where EV utilized in the second line setting post chemo and immuno maintenance, avelumab maintenance. The survival is very good, reaching 40 months. So this is what is desirable. So I think that is important. So we have seen such toxicities, both skin rash, neuropathy. And what happens, a lot of patients have residual neuropathy. So 50% patients had residual neuropathy grade 2 or more. So that is a persistent toxicity. Rohit sir, how do you see this neuropathic component? I think that is a very detriment to quality of life. You've seen it in colorectal cancers due to oxaliplatin. We have seen it across many cancers. How do you see a quality of life impact of neuropathy in your practice?
So definitely quality of life deteriorates with the grade 3 peripheral neuropathy, more than grade 2, 3 peripheral neuropathy. And the patient who receives EV generally, as you had said already, 80% of them develop peripheral neuropathy, and 50 to 60% of them have this residual peripheral neuropathy. So I had used in the second line in 2 patients EV, and both of them developed peripheral neuropathy. One developed grade 3 for skin toxicities, and grade 3 peripheral neuropathy was there in both of these patients. So I think the peripheral neuropathy and skin toxicities, these two are very much dreaded complication of EV, as compared to chemotherapy followed by this avelumab maintenance.
Completely agree, sir. So EV seems to be a option, good enough option in second line, but in first line, where you are likely to utilize it for a very longer duration, I think that's a problem. And these patients developing neuropathy after just 3 or 4 months of starting EV plus pembro and persisting neuropathy throughout their life, remaining life, I think that's too much to take actually. So we believe to utilize EV. If it is a good drug, utilize it in second line. We have phase 4 trial also. Patients are welcome to be referred from the entire country, and we are receiving patients from entire country, including South India and far off from Guwahati at our center. But yes, we prefer to utilize in the second line settings. So these are the modified EVITA criteria which I tried to highlight: performance status 2 or more, HbA1c raised, creatinine clearance below 45, any corneal or retinal abnormality, pre-existing neuropathy. These are the flag points, and these are EV eligibility criteria actually. So that must be taken, and that is very important. So patient eligibility is important, and we have seen that in our patients in the real world setting. If we see this trial of Javelin, around 90% of the patients will be eligible in our Indian settings, while checkmate regimen only 40 to 50% will be eligible, and around 60 to 70% patients will be eligible for EV plus pembro. We have now multiple real-world evidence data sets as well from Europe, Asia Pacific. Our own data was also presented by Dr. Amol sir, that has been published and presented in ISMPO conferences. It is clear that yes, response rates are important, and in the first line data sets, EV plus pembro, the real-world overall response rates are not so high. In the real-world data sets, overall response rate in the United study of 100 plus patients, overall response rate were 50%. And 12-month PFS was 30 months. So yes, As it seems that in the randomized trial, the response rate to the tune of 70%, it got down to 50% in the real world setting. And this again, data sets highlights that it might not be as effective. This is the data. It has highlighted that 70% overall response rates in the original trial, but real world data sets having much lesser response rates. Some single center results have been as low as 40% in terms of overall response rate. So we must agree that EV plus pembro, though it seems to be promising, but might not be the answer to each and every patient. And we must select the regimen well. Patients who are fit enough to receive chemotherapy and have a moderate disease burden can be given the standard treatment which is presently available with the largest OS data. And second line EV and ADCs are giving much better results. And this has been proven by the evidence real world data set. So when real world data sets highlights the same, I think we are much more convinced that this is a good area. So this comparison screenshot, which helps us to understand how the patients are doing and how is the data sets. Though it's a cross trial comparison, median OS data reaching with EV plus pembro was 33.8 months, but it was with second line EV data evidence study, it is reaching to 40 months. With checkmate regimen, OS is around 20-25 months only, which is one of the least in among all trials. And there was no data of EV sequencing in checkmate data sets. So this is all help us to understand. We also see the grade C adverse event data. Javelin had around 20%. Checkmate regimen had around 62%. EV plus pembro is also around 56 to 60%. So it is ultimately the quality of life and the adverse events which are very, very important. The discontinuation rates with Javelin bladder was close to 10 to 12%, 20% with checkmate regimen, and close to 35% with EV plus pembro. So we must be aware of these data before selecting the treatment in our practice. Yes, this is what I tried to highlight. Best possible data sets, patients having best possible treatment outcomes with this combination of chemotherapy followed by avelumab maintenance, and then utilize EV in the second line settings and beyond. Utilize erdafitinib whenever feasible, though not available in the country, so utilization is very low. And we need to look at better biomarkers for selecting EV in our patients. With this, I would like to stop here. If there are any other important comments which any panelists would like to highlight, we can take that.
Akhil, very well moderated this panel discussion. I mean, I have very little experience about enfortumab vedotin EV, so I'm really not. I mean, but the data seems good. But if you see overall, I mean, after looking at all the three approaches, I really feel that the best is to use conventional chemotherapy in first line followed by avelumab maintenance. Not because this Merck conference, but still, because what I mean that if you see toxicity of EV with pembro and even with Gemcis Nivo, it's almost 66% adverse event and 56% adverse event. So in real world, like where we are practicing best is to use initial chemotherapy, gem, carbo, followed by avelumab maintenance. And as rightly said, in a metastatic setting, prolonging only OS is not important, but with that OS is a good quality of life, which is more important aspect, I feel.
Thank you, sir. I think you resonated with what I see and experience, our experience as well, sir. I think we can back to the organizing team for any further comments and actions.
Thank you, Akhil. That was really wonderful discussion. And I must tell you that when I was resident in Tata, we never had gemcitabine. So all our experience was only MVAC and DD-MVAC, which came later on. But because the growth factor were also not there. So giving DD-MVAC was also very difficult. So we learned on MVAC, but looking at the Gemcis data, I don't think that we should really go back to the DD-MVAC for any reason. I don't think so. There is any reason that we should go back. Results are comparable, least toxic. So it is always better that we stick to the quality of life of the patient rather than just there is a data available for doing that. And you rightly mentioned that the toxicity of the EV is also an important. But I must tell you that all ADCs have toxicities. we are learning all ADCs how to handle them. Look at brentuximab; it has got neurotoxicity a lot. Even the Kadcyla, what we have been using from last 10 years, it's still a toxic drug. Hepatotoxicity, marrow toxicity with thrombocytopenia is quite. And the new kid on the block, and her too, we all know the pulmonary complications are also there. So with the EV also, probably we will learn, because numbers are so small of the bladder, what we treat, so we don't have that much of experience of handling this EV. But looking at the current scenario, and as Amol said that he would stick to the chemotherapy followed by the data. And we always say that the look at the data and follow the data. 40 months, nobody else has given. So I would also agree that, in giving initial 4 cycles of chemotherapy rather than 6. 4 cycles of chemotherapy of GEMSIS, and then those who are in having stable disease or good response can go ahead with the maintenance. So thank you everybody. Those were my comments, and over to you, Ginder.
Thank you, sir. So it was an interesting discussion. So I have one question, Dr. Akhil, and of course, to the other panelists. So if we select a patient who might be platinum ineligible and we decided to go with EV302, so what will be the treatment options in the second line? So just wanted to have a comment on that.
So I think there we need many more drugs which are not yet available in the country. We see a lot of HER2 positivity. We did it as a part of a thesis of our DMS student. The HER2 positivity rate in our patients is close to 12%, which is quite a good number. And we are likely to have a disitamab vedotin trial, phase 4 trial in our hospital very shortly. That drug is under development and has got FDA breakthrough approval. And disitamab vedotin, if available in such 12% of the patient, would be a good choice. FGFR inhibitor, if feasible, and if the patient is having FGFR 2-3 alterations, that is another option. Apart from that, if nothing of that sort is feasible, utilizing again treatments like paclitaxel, nab-paclitaxel, or sometimes pemetrexed in this we utilize. Also, sometimes single agent gemcitabine. All these are the options, but response rates are likely to be much low, below 20% in most of the cases, apart when the targeted therapy is feasible.
I do understand. And so a question just following up on that. So EV is, as we all know, it's an ADC. So, but its chemo component is MMA, which actually targets tubulin. But there are, other ADCs which has different targets. Like we have topoisomerase inhibitors and other molecules. So, I mean, they will be a completely different drug. So, can then they be considered for the second line? Or maybe third line if somebody has given Evolumab in the first line maintenance and followed by EV and can be considered for the third line.
So presently, we utilize TDX as a second or third line treatment when HER2 is 3+. That is an approved treatment option. It is a tumor agnostic approval in second line and beyond. So we have utilized it in some of the patients because disitamab is not yet available in the country. Apart from that, no other ADC is yet approved in this subgroup, and we need more data sets in that area. Yes, ADCs are but the only part is that all the ADCs are targeting the similar components. And I think we need to have ADCs which have different chemotherapy component as well, because if a patient already has grade 2 or grade 3 neuropathy with EV, we will not able to utilize any of the ADC which targets a similar area and causes a similar overlapping toxicity. So that's the important point.
Thank you, sir. Thank you very much for your comments and for driving this discussion so nicely and giving us a lot of clinically significant insights. So we just assured that we are going to work on that. So I would like to thank my eminent faculty for taking out time for this session and preferring it over other priorities. I would also like to thank the attendees, the audience, which has sacrificed their weekend, which had just begun on Friday evening, and preferred the scientific meeting over other priorities, of course. So thank you so much, Dr. Mehbooba Sade, for chairing the session and driving the entire meeting in the right direction. I would like to thank my speakers, Dr. Sachin and Dr. Amol. Thank you, sir, for taking us through the global and Indian data. Again, a lot of thanks to Dr. Akhil Kapoor for taking us for having this wonderful panel discussion. And I would special thanks to the eminent panelist, Dr. Vikas Alreja, Dr. Satish Sharma, Dr. Rohit Swami, and of course Dr. Devopriya, Dr. Monica Bopanna. Thank you, everyone. With this, like every good thing, this meeting also comes to an end. I wish everyone a happy weekend and a happy good night, and we just look forward to have each one of you in the forthcoming meetings as well. Thank you very much once again.
Thank you. Great night.
Darshan, you can end the meeting now.
Sure. Yeah.